Good evening, everyone. Good evening. All right, we got a live audience. Awesome. My name is Alan Marston, and how many of you have actually seen me here introduce Diamond in the past? I know some of you have. Yeah. Most of you haven't, so I'll tell you, I'm one of Diamond's biggest evangelists, the HeartFit Clinic's biggest evangelist. 2 years ago, I ended up having a lot of problems. Diamond sent me a message on Facebook saying, you got to come and see me. I did, and I honestly feel I'm standing here today. My wife definitely feels that way, that I'm standing here today because of what the HeartFit Clinic did. And I'm not going to get into all of that this evening, but I'm always ready to give you a testimonial of what happened to me, where I was. I felt, maybe I wasn't, but I felt like I was a walking dead man. I didn't have the energy that I have today. You see me walking around like I'm on fire. I'm always moving around really quickly, but that's not the way I was. I was in bad shape. We've got heart disease in the family. My dad had a quadruple bypass when he was 54. I had a brother who died at 54. And so I also, and I've got other brothers that have discovered that they've got problems. So at 59, I got treated at the HeartFit Clinic, and they've got tremendous technologies, tremendous modalities, tremendous staff. I can't speak highly enough of what they do there. And you know what? They're saving lives, honestly. And I think it's the future that's happening now. And it's the future in the medical industry is going to realize that this is the way to treat heart disease, not by medication and not by what they do, right? So when I got into the HeartFit Clinic, and this doesn't happen for everybody, but when I got in there, I was on 5 medications. Diamond can tell you, I'm not making this up. I came out of that 6 weeks, 7 weeks of treatment, and I was on no medications, 0. So I was on high blood pressure medication, a beta blocker, statins, all that kind of stuff, cholesterol medication, and I came out with nothing. So today the only thing I take is a low dose aspirin every night. That's it. So I really believe in what they do, and I can't recommend them highly enough for that. So without further ado, how many of you know Diamond Fernandez? Okay, some of you do, so most of you don't. So I'll tell you, Diamond is the founder and director of the HeartFit Clinic, author of Beating Heart Disease. The book is in the back, by the way, a tremendous book. I've read it cover to cover twice now, and the only reason I read it the second time is I thought I'd missed some stuff, which I did, and when you read it only once, you miss some stuff, and it's got some important information in there. He's got a Bachelor of Science in Health Physiology, certified by the American College of Sports Medicine, Advanced Metabolic Cardiovascular Certification, Executive Board of CACPR, which is the Canadian Association of Cardiovascular Prevention and Rehabilitation. More importantly, he's a speaker for physicians at conferences on cardiology best practices and treatment. That's pretty significant. I know he went to Dubai and spoke in Dubai as well. Speaker for patients on how the HeartFit Clinic bridges the gap. So without further ado, ladies and gentlemen, please help me welcome Diamond Fernandez.
So how many of you are here because you want to prevent that first heart attack or stroke? First one. All right, cool. If you have another one, then we can help you too. Just want to get an idea. And how many of you have heard me speak before? So the rest of the room hasn't. Okay. The people that have heard me speak before, thank you for coming back and hearing me again. Always appreciate that. So once again, my name is Diamond Fernandez. I'm the founder and director of the HeartFit Clinic here. And I'm excited to talk to you about 5 myths about heart disease. And it's a really passionate topic that I am happy to discuss about how we can prevent and reverse heart disease. Would it be okay if I just share quickly a little bit more about myself? So for those of you who don't know, I used to work at Total Cardiology Rehab. I'm dating myself. So from 99 to 2005. In 2005, I was headhunted to go start up a clinic in Dubai. I did that for a year, and then I went to Kelowna. And in Kelowna, I got I was just managing that program intern for a little bit there. And then I started the HeartFit Clinic in 2007. So I'm going to talk about the 5 myths that you must know about heart disease. And the first one I'm going to talk about is I am a male, 55 years old, with a family history of heart disease. How many people hear that all the time, right? So the reason why I'm calling this a myth is this is actually true. However, the majority of people that have heart attacks and strokes don't always fit this category. And so that's why I'm keeping it as a myth today, because it's important to understand, firstly, I'm a male. For those females in the room, I'm sadly to say that actually females and heart disease, stroke will kill more women than all cancers combined. And you get a lot of media about breast cancer. It puts it well behind. Now, I'm not trying to dismiss those cancers. I think they're very important to address. But what I really want to get here is that heart disease and stroke get women too. And it's a leading cause of death of men and women, and I want you women to understand that this is always important to do. With women, it's always tough because they're always wanting to take care of other people, take care of their children, take care of everyone. I mean, my wife's got 3 kids at home, and she's always worried about everyone else but herself. It's always important for those women out there to pay attention to yourselves that way as well. And so here's some key statistics on women. There's a bunch of them there, but really I want to get at, and I can give you copies of the slide. We're actually videoing the talk today. Really, there's 64% of women who die suddenly of heart disease had no previous symptoms. That's the big one I really wanted to share. So what are some warning signs that we should be aware of? Because women feel it a little bit differently than men do. With men, we get that crushing chest pain, we get that shoulder pain, sometimes we get a little fatigue, but men can also feel these symptoms too. And so when we talk about heart disease with women, a lot of women that I find who have coronary artery disease have jaw pain, have pain in the neck, pain between the shoulder blades. They feel the pain a little bit differently. Now they can still experience the chest discomfort, the shoulder discomfort. They can still experience those things, but it's important to understand that women can feel it differently. And here's a list of symptoms. And nausea is a big one. Indigestion type of feeling, cold sweats, fatigue. You can get fatigue for a number of days and you can end up with a heart attack. Now there are different types of heart attacks. And there are different types of heart disease as well. But today I'm really going to talk about coronary artery disease, which is the ones that clog up the pipes. You'll catch what I'm saying here a little bit earlier, but clog up the pipes. So when we talk about that, coronary artery disease is the big one that I'm talking about. There's lots of different diseases in terms of heart disease. There's structural problems, there's valvular disease, congenital disease, stuff that you're born with, birth defects. There's arrhythmias, irregular heartbeats. Those all fall under the form of heart disease. But what I'm going to talk a little bit more, and I have different talks on each one of those. Today I'm just going to talk about coronary artery disease. I'm happy to talk about other topics, but just not today. I won't go into the detail of it like I will today on heart disease. Let's talk about the next part of that is 55 years old. Well, I just heard one of my clients was just telling me recently a 39-year-old male had a heart attack, his first and only heart attack, passed away with his first and only heart attack. And it's really sad because this gentleman was super fit, was never smoking, it can happen to anybody. So when we look at these parts of it, 29 to 44-year-olds, that's pretty early, right? I'm 43. Thank you, I look young. At 29 to 44 years old, that's really young. But so many thousands of people, this is in the thousands, so 125,000 people passed away with a heart attack or had heart attacks last year that were between 29 and 44 years old. Surprising. And then you get into that sweet spot, 45 to 64. That's where the majority of heart attacks happen. And then we got 65 plus. And so you can see males are about the same here. Can we see that there? But then look at the females. It almost catches up right there. It's a really good chart to show that heart disease is not always related to age. And this is a complicated slide, but really all I want to share with this is that heart disease, coronary artery disease, actually starts early on in our adolescent years. Right? And so it can manifest itself, and we're going to talk about that a little bit later. It can manifest itself so that in our 30s, 40s, it's starting to build up. and it's starting to cause a little bit of concern that way. And then family history. So family history is a big one, and that's one of the reasons why I got into this. My father had his first heart attack at 38 years old. At 42 years old, he had bypass surgery. He's doing well, living, following our advice at the Heart Fit Clinic now. So he's, anyway, so 42 years old, he had bypass surgery. I have a family history of heart disease. So what can you do? It's not always about that, but understand this. This is the big part about it. Yes, family history puts you at increased risk for disease. We know that. It's specifically a 1.91 fold, which is a 1.91 increased risk versus someone that does not have a family history. But here's the bigger statistic, and this is why I put the family history in there. 70 to 90%, and it depends on the studies, it can go a little bit higher than this, are probably due to environmental exposures. So you don't always have to have a relative with heart disease. It can manifest itself due to environmental exposures. And so that's really what I want to share with that first myth, is that it doesn't always come to that. And so when we look at genetics, for those people that do have a family history of heart disease, it's important to understand where your risk is. But more importantly, understand that if you focus on lifestyle changes, smoking, blood pressure, keeping your numbers under control, and talking about exercise, and I won't get into that. That's a whole different conversation and talk that I'll get into today, not today. You can actually decrease your risk by half. So that's pretty good, right? So it's important that if you do have heart disease, if you have a family history of heart disease, that you do pay attention to your lifestyle so that you can minimize your disease risk that way. So one thing I'm going to talk about, and I can again have a whole different talk about this part, but I'm going to talk about telomere lengths. How many here have heard about telomeres? Wow, good, huge number. Telomeres are basically chromosome DNA, and at the end of these little telomeres, they actually shrink as we age, and basically they duplicate, these chromosomes duplicate, and if they get too short, they have the inability to duplicate, therefore helping healing the cells. And so if you have short telomere length, then that's something important to understand in terms of increased risk of heart disease and stroke that way. And a lot of other diseases, but telomere length is an important one to look at. What can you do if you have a genetic risk? These are some things that I have in terms of stepping stones as to what you can do. Some of them can be done at your family doctor's office. Some of them you have to come to the Heart Fit Clinic. But the idea is that, lipoprotein A is a good inherent marker to look at for heart disease and stroke. Apolipoprotein E, telomere testing, which I just talked about, and artery testing, which I'll get in a little bit more detail about with what we do at the Heart Fit Clinic. So that's myth number one, understanding genetic risk. So myth number two, many of you heard me speak about this, and I talk about how cholesterol causes heart disease. How many believe this is to be true? Oh, we're starting to change a little bit. Okay. You guys have been learning. Wow. So where does this come from? Back in the 70s, when I was born, I remember the study. I'm just kidding. They sliced open an artery, and inside that artery, guess what they found? Cholesterol and fat. And so that's where the whole fad of diet came into play, and saying, okay, well, we got to minimize cholesterol and fat because that's what's causing heart disease. And so we all think about cholesterol just accumulating to the arterial walls, and it builds up, and we end up having a heart attack. Well, that doesn't really happen this way, and I'm going to take the next few slides to explaining how cholesterol is a part of the heart disease process. So here's the fact. Can you see the difference here, or the picture I showed last? There's a little layer of skin holding that cholesterol in play. Okay? So imagine your arteries. Everyone just take your circle, your index finger and your thumb, and that's what the inside of your artery looks like. It's all skin, right? There's different layers to that, but what happens is that cholesterol builds up inside a layer, so the blood's still flowing. It doesn't just float around. It doesn't just flop around. So it builds up just like a pimple would on your face. Imagine a pimple building up inside that layer of the artery wall. It's protected, right? The pimple's protected. It just doesn't flop around in the wind, right? Hopefully you don't have that. So I had one yesterday, and I think it came off there, so good thing. So we've all heard about the good, the bad, and the ugly. So we all have these different cholesterol numbers, the good, the bad, and the ugly, right? So we got the good cholesterol, HDL, the bad cholesterol, LDL, and then we got the ugly, which is triglycerides. And here's the big statistic that I want you to walk away with today, is that the majority of people that have heart attacks and strokes actually have normal cholesterol profiles.
So we're not going to get rid of Trump.
There's some must-know statistics about heart disease, and I got the studies that I'll show in the next slide here. But 50% of people have normal cholesterols. Majority of them have normal good cholesterol. Triglycerides, which is the ugly. 70% of them have normal triglycerides. And here's the big one. Normal LDLs. This is LDLs that we would not treat. 83% of people that had heart attacks and strokes, 83% of them had normal LDL cholesterol. And then there's a lot of them that have, a lot of times the first symptom is just a heart attack, right? And so this is the guidelines, and just get with the guidelines. This was analysis of 136,000 patients, and you can see the data as to what I was saying there. But LDL cholesterol, the bad cholesterol, is not bad or not that bad inside of these people that have heart attacks and strokes. But 3.34 is not a treatable number yet if you don't have heart disease, right? If you do have heart disease, then we want to get that number a little bit lower. But I'm talking for people who have not experienced the heart event. So the question was, the data is a little bit compromised because of that part of it there. So yeah, that's the difference with what's going on. So you have to understand that if you do not have, so what happens is if you've not had a heart attack or if you've not been diagnosed with coronary artery disease, the numbers are a little bit more lenient. Once you are diagnosed with coronary artery disease, these numbers get more aggressive, right? And so that's the difference with that part of it. But when we're looking at why, and I'll talk about it in my myth number 4, we have to look at LDL cholesterol. It comes in 2 different sizes. And I always like to talk about the tennis balls and the golf balls. Do I have any tennis players in here? You should have. That's the balls that we actually want. The larger the better, right? And golf players, I'm sure I got some golfers in here, right? So I'm still trying to learn since I was 14, I think. So anyway, so it's important to look at the smaller, they're more dangerous, right? The more dangerous they are. And so imagine the artery. It's protected by a tennis net-like structure, right? Tennis balls do not go through a tennis net, but golf balls do. And so when we look at this, here's a list of all these people who've been told, hey, you have normal cholesterol. But here you can see David and Maria, sorry David and Maria in the audience, but they actually have smaller size particles. They have more golf ball size particles. So they become more dangerous, more atherogenic, or what I call plaque causing. So that's the important thing is to look at when we look at cholesterol.
So is that like the lipoprotein A?
No, this is different than lipoprotein A. Lipoprotein A is an inherent marker that we're looking for. That's a genetic marker. This is looking just for LDL, which is the bad cholesterol. There are different types of plaque-causing cholesterols out there, but LPA is one of them for sure. LDL is another one as well. So, but here, if you have high cholesterol, but you have larger size particles, you might be saying, okay, let's consider treatment when you really shouldn't be. That's important to kind of look at. It's important to look at the person as a whole to see what would be best. But let me talk about how cholesterol comes into play and really what happens. I'm going to explain this crazy diagram in about 6 steps here. So step number 1, you have these endothelial cells. So this is where the blood flows. Tell me if you follow me here. So you got the blood flowing, right? You got the layer of skin that protects where the blood flows, and then you have the artery. Now inside that artery is what we call the subendothelium. This is where all the damage occurs. This is where the pimple builds up inside the artery. So number 1, the first thing that has to happen is the endothelial cells get damaged. How they get damaged? That's a lot of environmental factors. Okay, so we won't talk about that too much today, but I'm happy to answer questions about that. Number 2, then you have those small particles that are floating around the bloodstream, the plaque-causing particles. Number 3, then they get oxidized. That's why your vegetables are so good for you. Antioxidants are so good for you. So once it gets oxidized, then number 4 happens. These monocytes, which are called white blood cells, they come in and seep through the inner lining of the arterial wall. It then becomes a macrophage, which then becomes a foam cell, which causes a plaque. So you can see it's quite a process. Is cholesterol the problem here? No, it's not the reason why people have heart attacks, and I'll explain in a second. But you can see how it builds up. It actually goes through an atherogenic or plaque building process. So it's important to understand your cholesterol numbers and what it means and what's going on with a little bit more detail. So I have this, okay, so I'm gonna feed you through that process, the 6-step process that I just was sharing there. And you can see here, okay, I'm gonna put you through this. So here's the lining of the arterial wall, and this is where the blood flows right in there. Okay, so this is the blood flowing here, and you have these small particles that respond to an area of injury, and we're going to watch it go through this part of it here. So this is now the inner lining of the arterial wall. These small particles break through the barrier. They get oxidized now. You can see them turning yellow. So that's not a good color to be inside your bloodstream. So once it turns into that color, yellow, simultaneously you got these monocytes or white blood cells that are floating around looking for these areas where there's an oxidized or broken down LDL particle. So you'll see the white blood cells start to come in there. You'll see these larger ones, molecules here. So they'll come to the area, these are the endothelial cells. This is zooming in quite a bit inside an artery. They'll seep through. They'll now go inside the area where the blood's flowing. Once it comes in here, these monocytes or the white blood cells become and eat up these oxidized or broken down cholesterol particles. Now it becomes a foam cell, and then that builds up inside the artery. So you can see that process as to how that happens. That's exactly how cholesterol, or how the process, now it's a lot more complicated than that. I tried to simplify that, but it's a lot more complicated than that. But that's like a little bit overview of what happens. So an outer space view is cholesterol causes heart disease. We're going to zoom in a little bit more, and that's truly what happens that way. So that's the process of what happens. So that's the atherogenic or plaque building process. So what can you do to understand your risk? I think it's important that we look at particle size testing. And then the other thing is, of course, is artery testing. Because then myth number 3, it's a plumbing problem. Right? How many people feel that, you have a cheeseburger and fries and you start to build cholesterol inside your arteries? And many people think of this, and we think about, okay, well, I keep on eating these cheeseburger and fries, and I have the last one, and that last cholesterol comes in and blocks it up. It doesn't happen that way. It's furthest from the truth. So let's get into that. I want you to repeat after me and tell your neighbor this. I always do this for those people that listen to me. Arteries are a muscle, not a pipe. Go ahead.
Arteries are a muscle, not a pipe.
If you don't listen to anything I say, that's the number one thing I want you to walk away with today. Arteries are a muscle, not a pipe. Because how we clear up a clogged artery, or clogged pipe, how we clear up a clogged pipe is a lot different as to how we should think about clearing up a clogged artery. So clogged pipe, what do?
Snake it. Drano.
Snake it, Drano. Throw some stuff in there, right? Clean it out. You do that to an artery, you're going to hurt it. You're going to hurt the skin. You're going to make it worse, right? So here's a big stat I want you to understand and walk away with as well. The majority of people that have heart attacks and strokes actually occur with blockages that are less than 50%. For those of you who haven't heard that before, that's quite crazy to hear, isn't it? The majority of heart attacks and strokes occur with blockages that are less than 50%. Don't believe me? That's okay. I don't mind that. Remember how I talked about the analogy of the pimple? Everyone's had that pimple pop, right? I had it happen this weekend to me. It's not good. Anyway, when you talk about the pimple popping, if it pops, that cholesterol plaque pops inside an artery, it can go from a small blockage to a large blockage very quickly. Here's the data on it. I don't want to get too much into it, but this is the studies. 68% of people that have, in this study, 68% of heart attacks actually occur with blockages that are less than 50%. In fact, the majority of them were around 25-30%. 68% of people, 68% of heart attacks occur with blockages that are less than 50%. 18% of heart attacks occurred between 50 and 70%, and only 14% occurred above 70%. Let's look at this data. This is a really important chart to understand because cholesterol builds up inside this artery, and then you have this pimple that pops, and it goes from here to here very quickly. That's a heart attack. Many people feel that heart disease just builds up like this last section on the artery right here. We keep on having those cheeseburger and fries, and it builds up, and we have that last one, and that's a heart attack. It doesn't happen that way. In fact, very minimal heart attacks happen that way, as I showed you. So this is a nice slide, and some of you have seen this before. There are different sections as heart disease. This is where you want to be. All of you want to be. You want to have a nice, thick endothelial wall, a subendothelial wall. It's nice and healthy. Here now it starts to get a little bit dysfunction. The cells are starting to get broken down here. It's what we call endothelial dysfunction. In this area here, you can start to see the plaque buildup or the cholesterol buildup. And you can see there's a small layer of skin holding that plaque in place. And then on this side is a heart attack. That skin can't hold that contents anymore, so it breaks open and has a heart attack. So, what can you do? Unfortunately, in your family doctor's toolbox, there's not much that you can do to see where your risk is of a heart attack or stroke. Yes, they can check your blood pressure, very important. Yes, they can check to see if you have diabetes. Yes, they can see if you're smoking. Adjusting those big risk factors are important. But there's not much, unfortunately, in their toolbox to see where your risk is of a heart attack or stroke. But what if you get referred to a cardiologist, right? What tests do they recommend on a preventative basis to see where your risk is of a heart attack or stroke? I'll ask you that. Stress tests, right? So stress tests, we walk on a treadmill, we exercise on a treadmill, we get our heart rate to maximum. Not a bad start, but stress tests it's what we call sensitivity and specificity of the test. They're not as accurate to see where your risk is of artery disease. And I'll explain this a little bit more. There's stress testing in terms of nuclear testing and stress echoes. I'm not a big fan of nuclear imaging, and I'll explain that in another talk, but it just involves a lot more radiation and radioactive dye that I'm not a big fan of. And so when we look at this, what about the prognostic value of stress testing? You can see looking at disease progression, these numbers are around 70% for people that do have heart disease. If we're looking for a stent restenosis or a new lesion for someone that does have heart disease, or even without any new lesions. This is where we kind of fail here. 35% of times we'll get it positive, 35% is maybe, it doesn't look like anything big deal, and the rest is inconclusive or negative. So why does that happen? Why are stress tests not the best tool to see where your risk is of a heart attack or stroke? Yes, it can look for coronary artery disease. The problem with stress tests is we're only looking at this last column here. We're only looking for advanced stages of heart disease. Our artery's got to be significantly blocked, about 80% or more blocked before it starts to show up on a stress test in a major artery. If it doesn't, hey, you got a clean bill of health. But you can still be on the path of a heart attack or stroke. So inflammation seems to be the problem with plaque encroaching into the lumen. It's important to understand that it's an inflammatory disease. And so what we do at our clinic is we look at things to look at some key inflammatory markers and protein biomarkers to see where this risk is of a plaque popping or a pimple popping. That's what we call a protein unstable lesion test. So what can you do? If you want to know where your risk is of a heart attack or stroke, it's important to look at the protein unstable lesion test and also some artery testing that you can get done that's specific to what we do at the HeartFit Clinic. So myth number 4, medications will protect me. Now, I'm a very big fan of medications early on in a disease process. And the big medications that we'll talk about are cholesterol, blood pressure, diabetes. If you don't have control over these things, it's important at least get some control over it, focusing on those big 3 medications. There's some blood thinners and stuff like that. I have a whole talk just on medications. We won't do that today. So there are always risks of a medication and there are always some benefits to medication. So it's always important to understand those 2 things as to what happens with it. What I want to educate you today is to understand that medications are not going to be the only thing that's going to save your life. People think, okay, I'm just taking a medication. I can eat what I want, not have to worry about exercising today because I'm taking my medications. I want you to kind of throw that out the window and understand, okay, what more can I do? What more can I do? One thing that I want you to understand and at least ask your doctor is what is the number needed to treat? How many people need to be taking that medication for one person to benefit? There's always a number. So just give you some examples here. If you're taking an antibiotic drug and 11 people take that medication and 10 people benefit by taking that medication, that's the number needed to treat of 1.1. 11 divided by 10, that's the number needed to treat of 1.1. 100%, 1 is perfect. That's exactly what we'd love in all medications, but not all of them are like that. Antibiotics, if you look at them, they might have a number needed to treat of 5, meaning we need to give that medication to 5 people for 1 person to benefit. We can live with those odds. They're not too bad. But when we talk about cardiac medications, this is what I don't like, is that we get the wrong data and we're talking about relative risk versus absolute risk. And when we talk about, for example, Lipitor, biggest, most prescribed drug in the market in the world today, 36% reduction in heart attacks and strokes. I would take that medication. Who wouldn't, right? 36% reduction? Sounds really good. But when we actually climb in deeper to those numbers, this is what the difference is. What it means is that 2 out of 100 people had a heart attack or a problem taking that drug, a heart problem taking that drug, whereas 3 out of 100 had a problem who thought they were taking that drug, so the placebo group, right? So 2 different numbers. But when we skew the data, that's how we get to about 34% that way. When really the truth of the matter is that the absolute risk is only 1 person in 100 that we actually save. Does that make sense? And so the number needed to treat here, if it's only 1%, is 100, meaning that we have to give this drug to 100 people for 1 person to benefit. Now, if you're not going to do anything, medications are very important. But we want you to do something. So I'm just going to talk about some drug trials here. 74% reduction in LDL cholesterol, the bad cholesterol, very important. Very nice thing to see. So if we talk about, because I know this question will come up in the audience and some of you are thinking about it, cholesterol-lowering drugs on a preventative basis are on a preventive basis, meaning you've not had a heart attack or stroke. I think the best I've seen is around 76, 77, somewhere in that range, maybe in and around there. It depends on the study. So all of them are a little bit different. Now I'm saying if you've not doing anything, that's good. At least take that. It's important. But there's more that you can do. It's important to understand cardiovascular disease risk that way. So there's also called something number needed to harm. So how many people are taking that medication that have a harmful outcome as well? So those are important questions to ask your doctor. Number 1, I'm taking this medication. What's the number needed to treat? What's my odds here? And my absolute risk odds, not relative risk, absolute risk. And then the second question you need to ask is, what's my number needed to harm? How many people are taking this medication that actually have problems or the side effects from it? Again, I don't want to get too much in the detail of all the medications out there. I do have a talk that we do about that.
So do you think that the doctors really know this number that you're normally talking to?
I'm going to say, and I'm not trying to be disrespectful because there might be some physicians in the audience here, we do get referrals from doctors because they understand that part of it. But most physicians are playing an odds game anyway, right? So they're saying, okay, well, I'm going to give you this drug because when you walk out of this office, that's one thing I can at least guarantee that you probably will do, right? And so they take out the prescription pad and give that to you. Now,
1 out of 100, that's a 1% chance of it helping. It seems almost like a waste.
that's not for me to decide, that risk, right? I mean, a lot of people put money on the roulette table and hope for 1 in 36 numbers, right? But yeah, it's important to understand. I think many physicians, unfortunately, can't be involved and understand everything. So you have to look at, okay, they're looking at a problem solution. And I think if doctors have more time, they have more time and it's all about you when you come there, they're able to dive in deeper and say, what more can we do to improve that number, right? It might be taking that medication plus starting an exercise program or plus focusing on your nutrition heavily or whatever it is. We can bring that number needed to treat a lot better, right? But I'm here to tell you that medications is a myth in terms of thinking I'm going to take it and I'm going to be okay. That's not true. Going back to the primary endpoints here in understanding this, there's a placebo group and the people that are taking the drug, and composite endpoint means a death, heart attack, stroke, or revascularization, something bad happening. And when we look at the difference there's only a 1.5% difference reduction in that. So that's a number needed to treat around the 70s, right? So we've lowered your cholesterol by 74%, but we're only getting a 1.5% absolute risk reduction, right? So it's more than just numbers. And some things, I just put these slides up here to understand this. Dyslipidemia is abnormal cholesterol. If you have abnormal cholesterol, it's probably important to look at your nutrients, micronutrients, to see where your deficiencies are. If you have high blood pressure, what deficiencies are you having from a micronutrient level? And from a diabetic side of things, if you have diabetes or poor blood sugar control, where are your deficiencies that way as well? So I just put a handful of slides here to say what we can do. We get more in depth with it at the HeartFit Clinic, but that's stuff that we can kind of focus on. And my last point today is talking about stents and bypass surgery will protect me. We've all heard about these stents out there. And when you have these stents, it's a metal object going inside your coronary arteries. Now we know that your arteries are not a pipe. And so when we look at this, if you want to clear out that artery, or that if it looks like a pipe, sure, we can go in there and really rotor it out and throw some liquid Drano, and it's okay because it's got a metal lining to it. It's protected somewhat. If we do that to your artery, putting in a heart stent is not always going to be the best thing. And let me explain that. I'm going to give you a little caveat to what I'm saying here. Remember, there are different layers of arteries. There's different layers of muscle, and when we put in heart stents, it actually causes an inflammatory response to the arterial wall. So when should we use a heart stent? This is the important part. If we have artery disease here, there's differences in how we treat. Don't mind the content here. I really want you to look at the picture more than anything. How we treat each of these arteries are a lot different. So to explain to you, this is early stages of heart disease. This is actually a plaque rupture, the pimple popping. And this is a stable plaque that's building up over time. So what's the most dangerous of these three? Middle one, right? When should you use a heart stent? In Calgary, I think we have some of the best, and I go to the cardiology conferences every year. I think Calgary is probably definitely the top in North America on how we treat heart attacks and strokes. If you're going to have a heart attack or stroke, this is the place you want to be. That's when you want to put in a heart stent. An artery goes from a small blockage. So it can go from a small blockage like this. It can rupture, and then it can inflame, and it goes from a small blockage where you're completely fine, didn't feel anything, to now a whole artery is blocked. We want to open this up as quick as possible, right? It's a lot different than if we see something like that and say, let's just put a stent in there and we'll open it up a little bit and give you a little bit of breathing room. It doesn't work that way. A stent should be used only, in my opinion, and based on the literature, it's not just my opinion, but it should only be used when you're actually having an acute heart attack, or acute coronary syndrome, we call it. So I have this slide here. It's very complicated, but what I really want you to understand is that there's a red zone and then there's a green zone. If you're in the red zone, that's the emergency room. You're having a heart attack, you want to get that stent or bypass surgery, that's a lot different than if you're in the green zone and you're like, hey doc, I want to check out my heart disease, see if I'm at risk, and you do a stress test, and he's like, I see something there, let's do a nuclear test, hey, I see something even more, let's go in and do an angiogram, the angiogram shows, by the way, you have a 90% blockage here, we better open that up, otherwise you're going to have a heart attack. That's not true anymore. So, medications versus heart stents. This is actually the data to show what I'm talking about there. So what is the better option? Is the COURAGE trial. The COURAGE trial showed that medical therapy is just as good as a treatment option than putting in a heart stent in patients that have stable coronary artery disease. I'm not talking about heart attacks. We've already agreed. If you're having a heart attack, Calgary is one of the best places to be. If you're not having a heart attack, you don't want to put in a heart stent. Now there's time and places and there's some caveats to that part of it, but we know that medical therapy is just as good as a treatment option for doing that part of it. We actually now know, based on some literature that happened last year or the year before, was the ORBITA trial. It showed that putting in a heart stent is actually a placebo. So they actually had one group that was having heart disease or chest pain, not heart disease, but actual chest pain. They actually put in a catheter and they pretended to do that in the other group, and they found, hey, we got the same results. There's a placebo effect from doing heart stents. Believe it or not. And so it was a whole big media frenzy. I remember going to the conference and I'm like, oh, that's a bunch of, the study wasn't done right or whatever it is, or they're coming up with excuses. But the fact is that your arteries are not a pipe. And if they're a pipe, well, it means, we could think about, and cardiologists are not plumbers. They go to school a lot longer than plumbers do, I think. So, we're smarter than that. They're smarter than that part of it. And so, again, exercise versus just doing a heart stent in terms of patients that have stable coronary artery disease. And then there's ECP therapy. And external counterpulsation therapy is one of our other treatment options. So we focus on lifestyle therapy, which is important when you do have artery disease. We focus on that. And then external counterpulsation is another one of our treatment options. And external counterpulsation, there's many of you in the room that know about this, where we pump blood back up to the heart and we grow new vessels and improve heart function. So 3 things why we do ECP therapy is basically, and this is my favorite word, is angiogenesis, which means growing new vessels, growing new arteries. And that's what you do when you focus on lifestyle changes and medical supplements and nutrition, and as well as doing ECP therapy, where we grow new vessels and we improve the artery function, so the artery starts to function a lot better. And my talk's not on ECP therapy, but you can talk to me a little bit later from this part of it. I'm really talking about how do we treat stable versus unstable artery disease. This is an unstable plaque. This is a stable plaque. And this is what we want to turn. Arteries that look from here to here. Because your arteries are so they should function more like a muscle here. And people always ask me, well, I'd rather have this one because it's more open. And that's not true, because you can see that's the pimple, skin holding that pimple in place. It's not very good. Over here, it's functioning a lot more like a muscle, right? And so just to reiterate what I was saying with some other slides there, is that you got to watch out for strengthening this skin so we can protect that. So at worst case scenario, it's building up like this. Because when it builds up over time like this is of much more benefit to you than it is versus having a pimple popping. Because that's a heart attack. Then we're looking at heart damage and function problems that way. So, of course, we have a choice of deciding between health and disease. And just to summarize what I said today, majority of people that have heart attacks and strokes actually have normal cholesterol profiles. Majority of heart attacks and strokes actually occur with blockages that are less than 50%. I remember hearing this the first time and I'm like, God, I got to look more into that. I'm happy to talk more about that part of it, but it happens from pimple popping, right? And that's where we don't have very good testing to see where that risk is. So, in summary, we talked about 5 things. We talked about myths about gender, age, and family history. Very important, but I want you to understand it doesn't always have to be those things. Going beyond cholesterol, going beyond medications. Arteries are not a pipe. We know how that heart disease happens from a pimple pop. And then cardiovascular treatment options are very important. So, thank you very much.